Good evening, and thank you for joining us. I'm Deborah Livingston, and I am the Development Director with the Mayfield Education and Research Foundation. Welcome to our next installment of Spine Talks, our webinar series created to improve your spine health. We're picking up this evening after last month's webinar where we learned about minimally invasive surgical techniques, and tonight we are joined by Dr. Bryan Krueger here at Mayfield Brain and Spine. Dr. Krueger will help us gain a better understanding of abnormal spinal curves and ways they can be corrected. Now let's get started. We are pleased to have Dr. Bryan Krueger with us. Dr. Krueger trained with Mayfield as a resident and is now a neurosurgeon at Mayfield Brain and Spine. He specializes in all spinal pathologies, both complex and simple. Thank you for being here, Dr. Krueger. You may now begin your presentation.
Thank you very much for that nice introduction, and thank you everybody who's logged in for joining me tonight as we discuss spinal deformity and our current mechanisms for treating patients with spinal deformity. First, I'd like to begin our talk with principles and topics to help us better understand the spine. Then we'll move on to talking about what is spinal deformity and different types of spinal deformity. After that, we'll talk about how we treat patients with spinal deformity, including corrective surgery. And then at the end, I would like to share with you a few stories about patients who have suffered greatly from their condition and how we were able to help them manage this and ultimately correct their deformity and improve the quality of their life. So first, our backbone is actually multiple bones, 24 to be exact. And I hope you all can see my cursor here. I'm going to point out some things as I give this talk. First, we start in the upper cervical spine or your neck. There's 7 bones there. And I want to point out this cervical curve. It is a backward sloping curve that we refer to as a lordotic curve or lordosis. You're going to hear me use that term a lot throughout this talk. And I want you to kind of appreciate what that means. It's referring to the shape of the spine in a backwards sloping curve. Next, we have 12 bones in the thoracic spine. This is where your rib cage is located, your heart and lungs. And this is called a kyphotic curve. You can see how this is angling and curving forward. And down at the bottom, we have 5 bones in the lumbar spine. This too has a lordotic curve or a backwards sloping curve. Now, understanding these curves and their shape and what is normal and what is not normal is how we can diagnose and treat people with abnormalities of these curves and what we like to call spinal deformity. And to better understand this, it helps to understand how do these curves form? Why do we have curves in our spine? So if you can imagine a developing newborn in a mother's womb, tucked up in the fetal position, their spine is actually one big C shape or one big kyphotic curve. Now the baby's born, the baby's lying on their belly. One of the first things they do is lift their head up. Now lifting their head up is, working those muscles on the back part of the cervical spine or the back part of the neck. That's what develops this lordotic curve. Then a year or two later, as the child starts to learn how to stand up straight, this bottom part of the spine, the lumbar spine, then that develops its lumbar curve. So you can see how at once this was one big C-shaped kyphotic curve, now has these multiple curves, and that's how we are able to stand up straight as children and as adults. So understanding the anatomy of each individual level is important in order to fully understand why deformity develops. So each bone has a vertebral body, which is this cylinder aspect of the bone, and in between is a disc. We call these the intervertebral discs or the interbody discs in between the vertebral bodies, which is this area. Now these have motion. You can flex forward, backwards, and bend side to side. Additionally, in the back part of the spine, you have what we call facet joint. This is a joint just like anything else where 2 bones meet. They have synovial tissue, which produces the fluid that lubricates that joint and moves just like any other joint. You have one of these on each side of the spine, in the back part of the spine. So each bone joins at 3 different levels, and these joints allow each individual level to move just a little bit. And when you put all this together, that's where you get your flexibility in the spine. So you can see in this figure what happens when the spine is flexing forward, and then over here when we're extending back, you can see how these facet joints allow for that movement. Next, we need to adjust the concept of balance. And when I say balance, I'm not really talking about, you know, putting your arms out and walking on a balance beam or a tightrope. What I'm talking about is you need your head over your shoulders, over your hips, over your knees, and over your feet in order to stand up comfortably. If you bend at the waist and your head is way out in front of your back, you can only stay that way for a few minutes before you start to fatigue and develop tiredness, soreness in your back and in your hips. So what happens when the spine starts to degenerate as we age? Well, if things aren't in balance, the whole tower can tip over very quickly. And we'll see examples of that throughout this talk. So over here on the left, we have a figure of a skeleton who's standing in neutral balance. And what I mean by that again is you see the head over the shoulders, over the hips, over the knees, and over the feet. This is a very comfortable, neutral sagittal alignment. This word sagittal, all that refers to is side view. So when we're looking at someone from the side, this person is in neutral alignment. As we age, or if we develop some sort of deformity, which I'll talk about how we can how deformity develops, we start to see the alignment change. Now, this isn't that obvious, but this patient is not toppling over, but they're not in balance. This head is forward to the shoulder and the hips, but once again, this patient is not tipping over like they're falling off a balance beam, but the spine is not in balance. And as deformity gets worse, you can see if you were to try to stand like this skeleton on the right, that would produce a lot of fatigue, a lot of pain. It would be a very uncomfortable way to spend your life. So much so that this person can't even stand like this without tipping over. So they have to implement a few compensatory mechanisms. They have to compensate for the fact that their spine has an abnormal curvature. They're doing this by overextending their neck right here, produces neck pain. They're rocking their hips back. This rocking back of the hips leads to a lot of back soreness and hip soreness. And look at this, they're even spending their time with their knees bent at all time. That produces a lot of fatigue in the quadriceps. So this does not look comfortable to me at all. But unfortunately, when patients develop this spinal deformity, this is what they're looking at on a day-to-day basis. So how does this deformity cause? From a variety of causes. One, degenerative discs. So the discs in between the vertebral bodies can lose their height. So as they lose their height, this is the front part of the spine, you start to tip forward. These facet joints start to become very arthritic as we age, and they start to almost lock up. They don't move as well. So even if you wanted to rock yourself back or extend, the joints are kind of stiffening up and not allowing that. Additionally, you can have a slip. And so not only does a slip like this cause compression of nerves, which can lead to pain, but it changes the entire angulation of one segment. Now, if this was at the bottom of your spine and your head was way up here, this slip would cause everything to tip forward, kind of like that Jenga game that we referenced at the beginning. People can have fractures in their back, especially patients with osteoporosis. This can lead to weakening of the bones. When people with osteoporosis break have a compression fracture or a break like that, it changes the shape of the vertebral body. When you change the shape like that, it sends the entire spine out of alignment. And then lastly, previous spine surgery. So we didn't always fully understand the consequences of spine surgery 20, 30 years ago. And so there's a lot of people out there that had spinal fusions that were not in the right alignment. And this can lead to this deformity that we talk about. Actually, over 50% of people who are over the age of 60 have some level of spinal deformity, and as we age, that prevalence goes up. It's almost like we come out of the womb tucked in the fetal position, we learn to stand up straight, we live our life, walk around, and as we age, it's almost like we're regressing back to that fetal position as we're hunched over. So what are the different types of spinal deformity? Scoliosis is a type that I'm sure many people have kind of heard of, at least, but what scoliosis is this curvature, this side-to-side curvature. And here's an x-ray of a patient with a very dramatic scoliotic curve. And actually, this is a picture from one of the patients that I'm going to tell you a story about at the end of this webinar. There's kyphosis. So I use the term kyphosis when I was talking about the natural curvature of the thoracic spine. But when we have a global kyphosis, we're referring to the entire spine being too far bent forward. And here is a picture of another patient I'm going to talk to you about. And believe it or not, these are the same patients. So this patient has a scoliotic curve and a global kyphotic deformity. And then we also have cervical deformity. So cervical deformity is referring to deformity within your neck. As you can see, this lady's looking down at her phone. She's a young lady, and this, believe it or not, can lead to it. So I'm not necessarily advocating that we all walk around like this with our phones up in front of our face, but I have a feeling that over the next 30 years, we're going to be seeing a lot of problems due to our entire population constantly looking down at their phones. And actually, it's not just a hunch. We're starting to see this. This article is a chiropractor talking about children becoming hunchbacks due to their addiction to their smartphones. And over here, you see an x-ray. If we look up at this cervical spine, you could see that the natural lordosis we're supposed to see is, believe it or not, being lost in some younger people, including children. As you can imagine, if you spend your life looking down at your phone in this position, that is not going to lead to good long-term spinal alignment. Now, I'm not advocating everyone wears a cone around their head to prevent themselves looking at their phone, but somebody's got to figure out a solution to this. Otherwise, we're going to have a lot of issues in the future. Lastly, I want to talk about adjacent segment disease. So the concept of adjacent segment disease is one in which we have a disease level that gets operated on. Maybe it requires a fusion. So you can see here, pedicle screws, a cage, bone graft. At one point, this was a disease level where the patient was having symptoms. The surgeon decided you need a fusion. You get the fusion, everything heals well. Well, it turns out that this level, whatever level it may be, was probably contributing a lot to the mobility of the spine, which is why it degenerated over time. Now you fuse it together, and that level no longer moves. So this level up here and down here, they have to pick up the slack and move more to maintain the normal mobility of your spine. This leads to accelerated degeneration. Now, some people say, well, maybe those levels would have degenerated anyway. How can we know for sure? Either way, if you had a lot of mobility at this segment and you take it away, it's intuitive that these levels would have to pick up the slack. So this adjacent segment disease can be a cause for deformity. Here's an example of another patient I'm going to talk about at the end, tell you her story, where she had her entire lumbar spine fused at one point. Now, if you get all the mobility in your spine, more so in your lower back, what happens when you fuse it all? Well, this area above it is likely going to need to contribute more towards the motion, and this lady did in fact develop adjacent segment disease, a sharp kyphotic deformity above the level of the surgery. So what happens if you do have a deformity? What are the treatment options? Well, just like anything, we start with kind of the least invasive possible. So different medicines, anti-inflammatories, pain relievers, even a pain pump perhaps. We enroll people in physical therapy. We trial bracing, maybe some steroid injections, radiofrequency ablation. Now this is a procedure where you can block the nerves that innervate the spine and cause the pain, And then ultimately, if all of our non-operative management strategies fail us, we have to consider surgery. So what do we consider when we're talking about surgery? Does the patient really need a deformity correction? And when I say deformity correction, we're talking about a misshaped, male-aligned spine. So a spine that is out of alignment, out of balance. Do they really need their whole spine corrected? Do they need the surgery to change the shape of their spine? Can we do a smaller surgery? Maybe something like a discectomy where we just treat a herniated disc, or a laminectomy where we just take the back part of the bone off and give some space for those nerves. Is the problem really the spine? Does the patient have an issue with their hip, or is it a muscular problem? What is recommended in an ideal world? So can we dream up a perfect surgery? Is this really achievable? Is it tolerable? You know, we have to give consideration to a patient's age, disease process. People with renal disease have softer bones. People with osteoporosis have softer bones. Will their body tolerate such a dramatic, large surgery of correcting somebody's spinal deformity? You know, we talk about this a lot, but these really are serious operations, and sometimes they can take up to 8 hours, and that's a lot of time under anesthesia. Sometimes it's a long hospital stay, and the expectations for recovery are something along the lines of 6 months to even up to a year. So it's a big deal. It's a life-changing surgery, but you gotta go through it to get to the other side. So this is not a decision we take lightly when we're considering someone for this surgery, but it's just like anything. There's a risk-benefit profile, and if the benefit seems to outweigh the risk, then we have the means to go for it. So how do we plan these surgeries? Just like anything else, measure twice, cut once. You get one shot at it. So here's a paper by our own Dr. Charlie Kuntz, who unfortunately passed away in 2015, but he was a very important person, an important mentor, teacher, researcher. He was part of the Mayfield group, and he was a big pioneer in deformity surgery. And so what did he do that was such a big deal? He basically defined what the spine should look like at its baseline. He defined what a normal spine should look like. So we can take anybody with deformity and measure all their different angles of their spine and say, this is not what it's supposed to look like. Reference Dr. Kuntz's paper, this is what it's supposed to look like, and we can plan our surgeries based on the work that he did. So as you can see here in this figure off to the right, this is looking at different angles at every different level in the spine. And this study measured asymptomatic adults in what their curvature was. And we use these measurements today to plan our surgeries out, and I'll show you some examples of this. The normal posture, once again, head over the shoulders, over the pelvis, over the knees, the feet. We have our normals, and we even have equations where we look at things like pelvic incidence, which is a measurement that shows the relationship of the tailbone or the sacrum and how it connects to the pelvis. We look at the lumbar lordosis, which is that lordotic curve in the lumbar spine, the thoracic kyphosis, and the cervical lordosis. And so not only are we mixing in some geometry, but we got some algebra here. We know how to do the math and make sure everything checks out. I'd like to give a shout out to my high school math teacher, Brad Fry. You know, you're sitting there as a sophomore in high school, you're like, when am I going to ever use any of this stuff? Well, it turns out once you finally get to where you're going in life, all this stuff is important. And so I find myself using geometry, physics, algebra every day. And it helps us not only define and diagnose a patient, but it helps us figure out how to correct them and put them back into normal alignment. So the preparation, we decide somebody has got a problem. How do we prepare? What kind of tests do we need to order? We have these really, really cool x-rays. You look at this patient here, they look fairly balanced from the outside, but you get an x-ray, you look on the inside, they have a major scoliotic curve. And then even here, their lumbar spine down here at the base of the spine has got a kyphotic or forward bending curve. Now this alignment looks painful to me. We also get dynamic x-rays. We look at people bending forward, bending back, side to side. This can show how the bones move on each other. It also shows us, is their deformity flexible? Are we going to be able to just manipulate their bones to the position we want? Or are we going to have to break up the spine, for lack of a better term, to get it to move? We also look at MRIs. These show the soft tissue and any compression of the nerves. We look at CT scans, which give us a very good three-dimensional bony anatomy. And then we look at different things like DEXA scans, other bone metabolism, lab values. We want to make sure that the bone is strong enough to withstand whatever forces we're putting on it with our deformity correction. So here you can see on the left here, these are both the patients I'm going to talk about a little bit later. We're measuring different values. I'm measuring her lordotic curve here at the base. I'm measuring her sacrum and how it relates to her pelvis. And I'm measuring how far forward her shoulders are in front of her hips. Additionally, when we're looking at a front view, I'm trying to figure out how far off center is the head and neck relative to the pelvis. And here we see, despite the scoliotic curve, this side-to-side curve, her shoulders are fairly in balance with her hips. It's fairly over the top. But if we look at a side view, shoulders are very far forward. Now we look over here, and this patient looks fairly balanced. Heads over the shoulders, over the hips. So is this really a deformity? Well, we look at how the pelvis relates to the sacrum, and we get this number called the pelvic incidence. And I measured that out at about 57 degrees. Now that's important because our lumbar lordosis should be in line with that number. And you can see here that these two numbers are very off. And so we have a mismatch of almost 30 degrees. Now you can see from all the figures I've showed you, this is a one big kyphotic curve. So even though this patient appears in balance, the only reason they're in balance is because they are using a number of compensatory mechanisms. This lady has literally rocked her hips back as far as she can just to keep her head up, and likely has a little bit of bend in the knees to hold herself up. And once again, this can be very fatiguing and painful and make a patient not even want to stand, just sit all day. You can see in the front view or the coronal plane, we are fairly good balance there. So this we're just illustrating here all the different measurements we take to make a diagnosis and figure out, does this look the way it's supposed to? And in both these situations, it doesn't. So once again, shout out to our very own Dr. Kuntz for showing us what is normal, so that we can kind of compare everybody else to that and help us correct their deformity. Here is the dynamic x-rays that I was referring to just a minute ago. You can see here on the left of the screen, we have a very curvy spine. So this is a scoliosis deformity. We like to take measurements of each of the curves, and then we can have the patient bend to one side and see. So for example, take a look at this in the middle of the thoracic spine, this curvature right here. Even when they bend to the right, this is still curved to the left. So we call this a fixed deformity or a rigid deformity. Now, if we look at the lumbar spine, we have a curvature down here, but when they bend to the left, this almost straightens out. So this is more of a flexible deformity. And so this gives us some insight prior to going into surgery about what we're going to need to do to properly correct this. So what are the types of surgeries we can consider? Well, there's the basics, which is decompression. So anytime a nerve is pinched, we can implement either a decompression surgery alone or as part of a larger surgery, and that consists of a laminectomy, foraminotomy. These are terms where we drill out a little bit of the bone and give the nerve some more space. There's a discectomy surgery. So I talked about the intervertebral discs. Those discs can sometimes herniate and pinch a nerve. So we can go in there and remove the herniated disc. Anytime a disease level is kind of falling apart, slipping, or very painful, we can consider a spinal fusion. We utilize bone graft, cages, screws in the bones, and rods. And this holds the bones together and allows them to heal together so they become one bone and fused. And then finally, we mix all these together. And not only that, but we talk about changing the shape of somebody's spine, and we refer to this as deformity correction. So here you can see this is our laminectomy, foraminotomy. We come in minimally invasive, or this can be part of a more open procedure, just giving these nerves some freedom, some space. We can go in and take out any herniated disc that might be irritating a nerve, and then here's that figure showcasing the spinal fusion. We put screws through this part of the bone right here, a cage in between to maintain that space, and bone graft to allow these to fuse. So what about the deformity correction surgery? Where does that fit in? How do we do that? So I talked about a couple things. I talked about flexible deformity, rigid deformity, and what we really need to do is, a lot of times people will, as they age, the joints in the spine become stiffer. They're harder to manipulate in surgery. So if somebody is bending too far forward and we want to kind of rock them back with surgery, we need to change the angle of their spine, change the angle of their curvature. So we can do that in a variety of ways. The first way, and probably the more simple and natural way, is to change the angle at an individual level. So we do this through we call it an interbody, or in between the two bodies. We can take out the disc and we can add a cage that has a certain degree of lordosis. And if we put that cage in there, we can literally change the angle at one level. Now, if you change the angle at one level, that will, if somebody is out of alignment by 30 degrees, they're pitched forward 30 degrees. If you can get 30 degrees of correction in their low back, that will have them stand upright and they'll not be so far forward anymore. So we're able to use these angled cages to realign the spine. This is a technique where we come through the front, and we usually reserve this for the lower regions of the lumbar spine, the lower levels. We also have a technique where we
Dr. Krueger, I think you're muted. You might have accidentally muted your headset.
Can you hear me now?
Yes, thank you.
Okay, where did I mute?
Just go back a slide.
Okay.
Thank you.
All right. So you can all hear me again. I apologize for that. There was a button on my cord that hit mute. Anyway, so going back to our surgical techniques for deformity correction, the first technique that we utilize that gives us a very natural way of correcting the spine is we address the disc, okay? And so we call this an interbody fusion technique, where we take the disc out and we can replace it with one of these cages. These cages have a certain degree of angulation. So if through all our measurements we find that somebody has a 30 degree or a 20 degree, let's just say 30 degree deformity, where they are pitched forward and have a hard time standing up straight, we can take their disc out, we can put in one of these cages. Say we put a 20 degree cage at the bottom level and a 10 degree cage at the next level. Theoretically, we can change the curvature of the spine by 30 degrees. And if you do that in the low spine, that rocks the whole body up and really gets them back into balance. Alternatively, for people for people with scoliotic curves, this lateral technique, so this figure right here is someone laying on their side and we're looking at the front of their spine. We can introduce the interbody cage in from the side, and this can straighten people out. So down here in the bottom right, we see the angulation of this disc space. It produces a curve off to the side, but if you pop one of these cages in, it straightens them right up. The next technique we utilize is called an osteotomy. An osteotomy just means a cut in the bone or a removal of a piece of bone. And we have different osteotomies. We grade them. We call them 1, 2, 3, 4, 5, 6. Easy enough. And this is different degrees of bone removal. So we can take out a facet joint here. So these figures are showing the 3 bones stacked on top of each other with the disc. We can cut out the facet joint. A lot of times these joints are stiff and the spine doesn't really move. You know, it's hard enough for the patient to stand upright, but even in surgery, we can't get it to move without making some of these cuts. Additionally, we can cut out a wedge of bone here, and I'll show you this really produces a dramatic correction. And then grade 4, 5, and 6 are used pretty much only in the most extreme cases. But these you can really free up the spine and manipulate it into the shape you want, and realign the patient so they're in balance. So that grade 2 osteotomy is a very common technique. So this is where we're just taking out the facet joint in the back. And what we get there is sometimes we can add 15 degrees of curvature, 10 to 15 degrees. So we cut out the facet and we rock the spine back, and you can see here, this is a fairly straight spine. And as long as these discs are mobile, we can change the shape or change the angle of the spine pretty well. We call this a Ponte osteotomy, named after Dr. Ponte, who created this. Alternatively, we can cut out the facet, rock it back, but instead of squishing that disc, this is more for people with kind of a stiffer spine. Sometimes it just cracks open like that. We call that a Smith-Peterson osteotomy. Either way, you can see the change in curvature through this technique. This gets us maybe about 10 degrees of angulation when we're utilizing this technique. A more dramatic technique we call the grade 3 osteotomy, or a pedicle subtraction osteotomy. We literally cut out a wedge of bone in the spine. So, you know, not to make it too graphic or anything, but we break the spine. You're literally breaking the spine, manipulating it, putting it where you want, and fixing it back together. So if somebody has got a very straight or kyphotic spine, you can cut this wedge out, rock them back, get them in much more normal alignment. Now, this is a pretty technical procedure. It's got a lot of nuances, but as you can see, this is what it looks like from a surgeon's point of view. You put your screws in the bones above and below where you want to do the correction. You remove the back part of the bone here so that you can see all the nerves and access that front part, the vertebral body. We call it pedicle subtraction because this little bony part where we put the screws in is called the pedicle. We subtract that or remove that and actually use that as our guide for where we're going to cut this wedge of bone. I personally like to use like a chisel, and under x-ray guidance, I use a hammer and chisel, and I cut this angle out. Once all the bone's removed, then you clamp it down and it changes the curvature. So I got this really nice x-ray of a pedicle subtraction osteotomy I did, and it really I just took the x-ray so that you can kind of see. Here is where we start. We put the screws into the bones above and below. In this x-ray, you may not be able to tell, but the back part of the bones have been removed, and all we're left with is this side view of the vertebral body. This next picture, you can see I've removed a wedge of bone. You can even see here this angle. And after that wedge of bone is removed, we have this temporary rod. We loosen these screws and we clamp it down, and you can see how dramatically it changed the angle here. And so that's about 25 to 30 degrees of correction just from that maneuver. So in addition to the osteotomies and the interbody technique, we utilize screws and rods to kind of reshape the spine. And this is a nice little video kind of demonstrating that. So as you see, after we open and expose the spine, we like to perform some osteotomies. We remove these joints. That kind of loosens things up. We place our screws in each bone, oftentimes using 2 or 1 screw per bone. And then we start at the bottom, hook them up to the rod, and as we go, we can kind of manipulate the spine to fit the rod into the appropriate shape. So where there was once an abnormal curvature, we can straighten that right up, lock it in place, and let it heal together. After the rods and screws are down, we put some bone graft, and that allows all this bone to heal together and become one big long bone. So about 6 to 12 months, this all heals together, like I said, big, one long, straight bone without that curvature. So how do we prepare for this surgery? Once you make the decision that you want to go forward with this, you need to minimize all the risk as possible, as much as possible. So this is a really large operation. It's elective, meaning it's not an emergency. The patient has chosen to undergo a deformity correction surgery. But given the lengths of surgery, the sheer size of the surgery, there's a lot of opportunity for complication. And so what we need to do, and what we have done over the years, is recognize what risk factors cause complication and do everything we can to minimize risk so that we can perform these safely. So we get DEXA scans, bone metabolism labs. These are all checking the integrity of the bone and whether or not they can hold those screws. You know, when we change the shape of the spine, those screws need to hold the bone tightly for quite a while. Hematological assessment, so we're basically looking at the blood. We want to make sure that the blood can clot properly. These surgeries tend to have a higher than normal blood loss, just given the length of the surgery, given the fact that we're cutting into the bone. We're looking at the function of the platelets, making sure everything clots well, making sure a patient is not anemic, that they have enough hemoglobin and red blood cells. Anytime we do a surgery like this, we want to maximize weight loss. It reduces the stress of the on the construct that we put together. Smoking can really hurt a patient's ability to heal well, both from a healing the wound and the bone healing. So we try to reduce smoking as much as possible and hopefully quit. Diabetic management, diabetes can also really impair the bone's ability to heal and the skin's ability to heal. So we want to make sure all these things are under control. And then lastly, you know, sometimes we need to do a psychiatric evaluation. This is a big surgery and it requires a tough mindset. And you need to be ready for the long haul because it is, you know, it's an extended recovery. But if you make it to the end, it's life-changing. So we need to make sure that people are mentally fit too to be able to go through this. Okay, so that is deformity and deformity surgery in a nutshell. And I'd like to share with you 2 stories about patients who had substantial deformity and what they went through and how we got them corrected. So this first patient I want to tell you about, she's a 67-year-old woman, and she came in with substantial back pain and right leg pain. Now she was diagnosed with scoliosis. She was diagnosed with scoliosis as a young adult. So she has what we call adult idiopathic scoliosis. And so she's known about this for a long time. However, later in life, she started developing these symptoms. So this leg pain was severe, consistent with the sciatic nerve pain. And this has been going on for about 6 months. And this pain gets worse every time she tries to stand upright. So she's kind of confined to a chair because anytime she stands up, her back and her leg hurt tremendously. So she's really unable to find any relief and says, "Doc, I need something. Okay, I can't live like this anymore." I want to go back and just kind of highlight some of these things. I showed these pictures earlier, but we see this major scoliosis curve. She's somewhat out of balance, but mostly fairly balanced in the frontal plane. But you can see she's very rock forward. She's having a hard time standing upright. So she has this global kyphotic curve to her spine. This is a CT scan, and you may not be able to make perfect sense of it, but I wanted to highlight just how deformed the spine is. You can see this bone is literally falling off this other bone. I can only imagine what that feels like. I'm sure that is painful. You see these major bone spurs forming. These bone spurs form when the bones are under stress. And so this just looks painful to me. This is an MRI of where that bone is falling off, and you can see on this side on the left, it's very wide open, but on the right here, that nerve, that pain in her leg, that sciatic nerve, we know where that's coming from. It's being pinched right here in the spine. We do that side bending x-rays. We bend her to the right, the deformity's still there. We bend her to the left, deformity's still there. So I know going into this surgery, this scoliotic curve is not going to be easy to straighten up. Okay, she can't even straighten it with bending. So what do we do in the pre-op stage? We got to analyze this, do all our measurements. We see her lumbar lordosis is 41 degrees, and we compare that to her pelvic incidence, which again is a measurement of how her sacrum or tailbone relates to her pelvis. And what this tells me is she needs 20 more degrees. If we could give her 20 more degrees in her lumbar spine, this would rock her shoulders back so that they're over her hips and put her head in line with her shoulders and her hips. So we call this the mismatch, the PI to lumbar lordosis mismatch of 21 degrees. So going into the surgery, I say, I need 21 degrees, or we like to keep it within 10 degrees. So I need anywhere from 10 to 20 degrees here. I look at the different rotation in the vertebral bodies. Not only are they side to side, but there's some rotational component, and I have to figure out how high do I need to go up to fix this. So then I develop my goals of surgery. One, I want to decompress the nerve root. She has that terrible pain going down her leg. I know exactly where the nerve is pinched, so I want to go to that spot when I'm in surgery and drill out the bone, make sure that nerve is decompressed and free. The second thing, we said, we got to correct that sagittal or that side view deformity to achieve that balance. Based on my measurements and calculations, I know I need 20 degrees. Okay, so I can't just put her on the table, put screws and rods in, and call it a day. She's going to wake up and she's still going to be pitched forward. I need to get 20 degrees of correction before we finish this surgery. Additionally, if I'm going to straighten her up, I want to make sure I stabilize the coronal deformity. I don't want to try to straighten her spine out only to find out that her shoulders are now way off to the right side. And then lastly, we want to minimize the stress on the construct. So if I put in all these rods that follow her bend, that's going to likely lead to broken rods. So I want to straighten up her spine to minimize the stress on this construct. So in the end, here's what it looks like. You can see she's shoulders over her hips, over her knees and feet. We kept her balanced in the coronal plane. We got her straightened up nicely. And so you can even see from her silhouette that she no longer looks like she has a deformity, and this looks like a much more comfortable position. And here's some before and after. So on the left, you can see she's hunched forward, shoulders slumped, having a real hard time standing up straight. And then here, this looks like a much more natural, comfortable position to stand in. And then with regards to the frontal view, the important thing here is that we didn't send her off to one side. We kept her shoulder over, or her head over her shoulder over the center of her hips there. So overall, we're very happy with this result, both radiographically and then clinically. This patient was very happy with the new shape of her spine. The next story I want to tell you about, this is another one that I showed you earlier, at least the pictures. This is a 71-year-old woman, presents with back pain. She previously had a fusion surgery from the L1 bone down to the sacrum. So L1, 2, 3, 4, 5 are all fused to the sacrum. However, when she stands up and starts walking, she gets numbness in her legs and she feels like her legs are weak and they're going to give out. So her pain and her deformity are really impacting the quality of life. Notice both these patients, they stand up and it's too painful to continue standing. So they're basically confined to a wheelchair or to sitting in a chair or sitting on a couch. Anytime they stand up, they just can't do it. I mean, that's what do you even call that? That's disability right there. You can't walk, you can't stand. It's completely diminishing the quality of her life. Now, she is neurologically intact. She doesn't have that sciatic nerve pain, no weakness. And if you look at this picture, and I kind of pointed this out earlier, her head is over her shoulders. It is over her hips, and it is over her feet. So is she really out of balance? But it turns out she is, because the only reason she's standing straight up like this is because she's compensating. She is rotating her hips so far back, which causes a lot of stress on the hips and back, and bending her knees a little bit to get her in alignment like this. And not to mention, when she does do this, it makes her legs hurt as well as go numb. So this is really not a comfortable way to stand for her. So we do our preoperative analysis, look at all our measurements, and I measure this curvature in her lumbar spine to be 28 degrees. So remember at the beginning of the surgery, I said previous surgery can cause deformity. This surgery was done so long ago, the surgeon probably didn't even know deformity was a thing. So her lumbar spine measures out to be about 28 degrees. We measure that pelvic incidence again, that's the sacrum and its relationship to the pelvis. And this is a fixed value, different in everyone. Hers is 57, so there's a mismatch between these two values of 29 degrees. So she literally needs roughly 30 degrees of correction to have a normal looking spine. I talked about rocking the pelvis back as a compensatory mechanism. We measure that. You see this number here, 43 degrees. We call that pelvic tilt. So the heads of the femur or the leg bone, and that angle, its relationship to the sacrum, we see she's rocking her pelvis back 43 degrees. And normally most people have about a 10 to 25 degree angle there. So we know she's rocking it back. Additionally, we can look at the slope of her sacrum, and the slope here is 14 degrees, and most people have about 30 to 50. So both these values confirm she is really rocking back in order to maintain that posture. So our goals of surgery, we're going to decompress that spinal cord up here at the top of the previous fusion. That's going to make it so that whenever she stands up, her legs don't go numb and feel like they're going to give out. And then that's not good enough. We need to correct this deformity so that she can be balanced without requiring all these compensatory mechanisms just to stand. And then obviously we want to make sure she doesn't go off to one side or the other. So we call that maintaining coronal balance, or that frontal view alignment. And so here's that figure I showed you earlier, the x-rays of us cutting that wedge. So I'm going to direct you down to these bottom three because I actually have the measurements in here. So this bone that does not have the screws in it is the L3 bone. So here's 4, 5, and 2 and 1 up here. So it's right smack dab in the middle of the lumbar spine. And if we take a measurement over this segment, there's about 6 degrees. Now we said I needed about 29 degrees of correction, and it turns out I cut a wedge that's about 27 degrees. And when I clamp that down, the new angle is 33 degrees. So 33 minus 6 is 27. So I cut a 27 degree wedge here, and sure enough, I get 27 degrees of correction over this segment. If you look at the after, you can see head over the shoulders, over the hips. She's properly aligned in both views. It's really nice to look at the before and after. You can just looking at it, you can see this after on the right is a much more relaxed, comfortable looking way of standing. And we look at here, you can see the correction, 28 degrees of lordosis. Now she has 55 degrees in the lumbar spine. And this pelvic tilt number is interesting. So you can tell she's not rocking back her pelvis as much just by looking at that pelvic tilt. So those are the two kind of patient stories I wanted to talk to you about. They're both dealing with the lumbar spine. I did mention earlier in the talk that we look at cervical or neck deformity. Here are some case examples of some patients that I took care of where we have severe kyphosis or a forward bend in the neck. We can do the same thing up there. This patient required a surgery where I came in from the front, added a little bit of height to the front, and then cut a wedge in the back and rocked him back. Same thing here. You can see this is a, believe it or not, this is a patient that was stuck in a position where they were looking down at the floor, looking straight down, could not look up. It's very difficult to walk if you can't see where you're going. And so this patient had a condition called ankylosing spondylitis. So their spine was fused due to an inflammatory condition. So the only way to reshape this spine is to break it, change the shape, put it back together. It's wild, but here you can see literally 50 degrees, 60 degrees of correction here. And now that patient can walk around looking straight ahead. All right, so what's the gist here? You don't have to live in pain. These patients with deformity, historically, we're told this is it. You're going to have to live with this. There's nothing we can do. But with modern technology and the new techniques and the familiarity that we have with these techniques and the comfort that we have with these techniques as we're doing more and more of these surgeries, the motto here is you don't have to live this way. Now, no patient's the same, but we have a lot of different tools in our tool shed to choose from to fix these problems. I highlighted a few of them today, but there's a lot more where that came from. Really, these are very involved surgeries, and we have to match the right surgery to the specific problem for any particular patient. But this surgery is very dramatic, but it can get you walking, it can get you upright, and it can get you enjoying life again. So thank you all very much for tuning in. I really appreciate your time and for joining us. And if there's any question, I'd be happy to answer those at this time.
Oh, you have to unmute yourself.
Am I muted?
I think Deb is muted still.
Thank you so much, Dr. Krueger. The bone graft, is this harvested from the patient or is it cadaver bone?
Thanks for the question. It's a combination of both. So when we do our decompression portion of the surgery, where we are removing aspects of the bone to free up the nerves, or when we are cutting the osteotomies and removing a wedge of bone, we save all of that, and that we use as bone graft. Now, when we do these large operations, that usually is not enough graft. So we need to utilize cadaver bone graft oftentimes to get the sheer amount that we need.
Okay. If curvature is mild, can it be corrected somewhat with physical therapy?
It can. There's a few things. There's a couple things that can happen. One, the curvature can be corrected with non-operative techniques such as therapy, bracing. Additionally, compensatory mechanisms can be strengthened to help maintain upward posture. Small deformity can be corrected with smaller surgeries, maybe at 1 or 2 levels. So yeah, the answer is yes, it can be, and it is definitely part of the strategy that we utilize prior to considering such a large operation.
Great. How many hours of surgery did it take for the 67-year-old that you had shown? Was this surgery done from the front, side, or back?
Right, so that 67, I believe, was the first patient I showed. This surgery was specifically done all from the back. And that is not what we always do, but sometimes, you know, if we feel we can do it all through one stage, that would be the first choice. Now, it's not always the best choice. Like I talked about with the interbody techniques, those interbody techniques are really powerful and they need to be done a lot of times through the front or through the side. Now, we can do these interbody techniques through the back, but we don't get the correction that we get through the side and the front. So we can do everything from the back. With that 67-year-old, we needed 20 degrees of correction. And we needed to get that correction from the base of the spine all the way up to T6. So we had a lot of individual levels that I could get maybe 2 to 5 degrees of correction at multiple levels that add up to total 20 degrees. And so what I felt like we were able to do is get a gradual change in the curvature and keep the surgery limited to one stage. So these are difficult decisions, but it's the planning and the consideration that goes into it that helps formulate this decision. Now, if it was a fixed deformity like the second patient where everything was fused, I can't get corrections at multiple levels because everything's fused. So I need to basically pick a spot, get all my correction at one spot, which is why I would choose the pedicle subtraction osteotomy in that consideration, in that situation, and get, 27 degrees or whatever I got on that second case, get 27 degrees of correction in one spot. Now, if we have flexibility, sometimes it's a little safer to distribute that correction over the course of many levels. And so that's why with that case, we went from the back. Now, as far as operative time, these surgeries, by ourselves usually take 6 to 8 hours. A lot of times here at Mayfield, we like to team up and find a partner to work with. We can get these surgeries done in a little less time, maybe more like 4 or 5 hours. And that's a big deal. 6 hours is kind of the cutoff. You start getting into 6 hours of surgery time or longer, and that anesthesia will linger a little bit, takes patients a little longer time to wake up. It increases the chance that they might need to stay in the ICU overnight. So we like to get these surgeries done as quick and as safely as possible to kind of minimize any potential complications.
Great. How much mobility do these patients have post full recovery period?
That's a great question. So any level that was fused is no longer going to move, okay? But what people maybe don't realize at first is that most of our flexibility and our ability to bend comes from where our leg meets our pelvis or our femur bone meets our pelvis. We call that the hip. So if you bend down to pick up a piece of paper, you're really bending at your hip. So try to keep your pelvis stable and see how much your spine actually moves. It's really not that much.
Okay, great. How much physical therapy is usually involved after such a surgery? Is it the entire 6 to 12 month period?
So this is really, it's individualized to the patient. I've seen patients require therapy throughout their entire recovery, and I've seen some patients that really don't even require any. It's almost amazing. So it really depends on kind of the fitness of the patient going into it, their condition going into it. It depends on how big a correction the surgery achieved. It depends on how well the patient bounces back from surgery. So all these things can be considered, but I would say it's anywhere from a couple weeks to many months of therapy that might be required.
Okay, I think we have time for one more question. I recently read about robotic spinal surgery. How do I know if this is right for me?
So robotic spinal surgery is in development, and it's being utilized here at Mayfield, both at our surgery center and at the hospitals we practice. The technology is really becoming quite compelling. At first, robotic surgery just was kind of like an interesting way of putting in screws. You do all the preoperative planning, and then the robot can kind of help you put in the screws. Now we have technology that helps us put in screws faster than the robot. So really what we need is the robot technology to become better than the surgeon. And so we're kind of hitting that point where the robot is making surgery faster or more precise. And so that, whether it's right for you or not is an individual conversation with your surgeon. And I expect as time goes on, maybe in the next decade, we're going to see a lot more of that, both here at Mayfield and around the country.
Great, thank you. Okay, great. I think this will wrap up our question and answer period. If you enjoyed tonight's presentation, please register for our next installment of Spine Talks when we pick back up on January 13th with Dr. George Mandiber. For more information about future Spine Talks webinars or the work of the Mayfield Foundation, please visit mayfieldfoundation.org. I'd like to thank everyone again for joining us and hope you have a lovely holiday season. Thanks again, Dr. Krueger.